welcome to all of you for this webinar, which is going to be our 121st episode. And as you can see here, this is the 121st continuous webinar that is being held every Wednesday. Welcome you all. And as you see, it's a very important topic, the anesthetic management in diabetes mellitus. And we have very eminent moderators and speakers for this. And we are highly grateful that you all could spare your precious time and gain so that the students get experience. This is very interesting. This is the ICA Con 2022, which is just got completed over the weekend. It was a very elaborate affair in the sense that the scientific program was very, very dynamic. And Dr. Sukanya Mitra, of course, did a very good job. And we had more than 500 delegates who attended. And you can see here the photographs of the 4 consultants who got the FICA fellowships this time, and also the program in which we had the 2 orations. And it was highly enjoyable and very admirable from the part of view of the Government Medical College, Chandigarh. To become a member, for those who wouldn't know that, you can join our ICA, which is the Indian College of Anesthesiologists, very easily. As it is shown here, you just go online and then you can do online membership filling as well as the depositing the membership fees. Next week, which is the 122nd episode, is another very important specialty that we will be covering, which is the onco-anesthesia part 2. And for this, I would definitely request all the students as well to join, because this is a new specialty and very few consultants and doctors have experience in this. So this would be next week. And today's program, as we have seen, that we are going to start with the anesthesia management of diabetes mellitus. And thank you very much once again. I think we can go ahead, please.
Thank you, Dr. Jayashree Sood, for the kind words. And I'm extremely delighted to welcome you to this 121st, that is 121st webinar of the Indian College of Anesthesiologists. And diabetes, as you know, is a common disorder which we encounter in our clinical practice. In fact, 30 to 40% of patients who have cardiac surgery have diabetes, and it's very, in fact, every second or third patient has diabetes. So it's a very vital subject, and we have an excellent panel of moderators and galaxy of speakers, experts in their own field at their center, working relentlessly for the safeguard of the patients. So with this, I would like to introduce Dr. Manjula Sarkar, who is the Chief of Anesthesia at the DY Medical College, DY Patil Medical College in Mumbai. And Dr. Kodandaram is a close associate, very well known for his knowledge in various subjects in anesthesiology. Dr. Murugesan is my own colleague in the multi-specialty section of the Narayan Hridaya Hospital, Bangalore. Dr. S.K. Mohanty may not be able to join because he's not well. And with those few introductory words, I would like to request Dr. Manjula Sarkar to take over and go ahead with the first presentation, inviting Dr. Megha. Thank you so much.
Thank you, sir, for kind introduction of the subject and mine. Without delaying, I would like to call upon Dr. Megha. She's internationally known personality, and she's going to talk on the definition of diabetes and types of the diabetes. She has done her MD and she's certified in pain and palliative care from Kidwai. Her current designation, she is professor and head of the department Anesthesiology and working at Chitradurga. Her area of interest is cancer of pain and palliative care services and obstetric anesthesia. She has multiple publications and presentations in the research work also. So over to you, Dr. Megha.
Thank you, ma'am. I'm trying my share screen. Is it visible?
Yes, it is visible.
Yeah, thank you, ma'am. So I'll go with the slideshow. Is it visible? Is it visible once again?
It
All
is
of-
Yes.
visible. It is visible.
It is.
Good evening, everyone. I carry warm greetings from my institute, Basaveshwara Medical College and Hospital, Chitradurga. No conflicts of interest to disclose. I shall be discussing my talk on these points: definition, types, pathogenesis, and pathophysiology. So before going into the topic proper, I shall address a few words on the history. Diabetes is a Greek word meaning siphon, means to pass through. Mellitus is a Latin word which means sweet. Apollonius of Memmis is the first to use the term diabetes in around 250 to 300 BC. By then, the ancient Greek, Indian, and Egyptian civilization knew about the sweet nature of the urine in this condition. Marin and Minosky in 1889 discovered the role of pancreas in pathogenesis, and Banting and Best obtained the purified hormone insulin in University of Toronto, and they were rewarded with the Nobel Prize, as we all know. Just 1 second, there is a technical issue. I'll just drop this bar down. Okay. By definition, diabetes mellitus is characterized by the By definition, diabetes mellitus is a group of disorders characterized by chronic hyperglycemic condition resulting from defects in insulin secretion or insulin action or both. The prevalence of diabetes mellitus is worldwide increasing. By around 2030, the adult population with diabetes mellitus could be doubled in number. So American Diabetic Association 2021 guidelines says that there's a normal glucose tolerance if the fasting blood glucose level is less than 100 milligram per deciliter, if the glycosylated hemoglobin is less than 5.6%, and a 2-hour postprandial of less than 140 milligram per deciliter. It is considered to be pre-diabetic or impaired glucose tolerance or impaired fasting glucose if the fasting glucose levels are between 100 to 125 milligram per deciliter, or the glycosylated of 5.7 to 6.4%, or a 2-hour postprandial of 140 to 199 milligram per deciliter. Over-diabetic is decided when there are symptoms along with a plasma random blood glucose of more than 200 milligram per deciliter, fasting blood glucose of more than 126 milligram per deciliter, glycosylated hemoglobin of more than 6.5%, or a 2-hour postprandial of more than 200 milligram per deciliter. Coming to classification, these are classified on etiological and pathological basis. So this slide gives an overview of etiological classification, where type 1 diabetes is purely an immune-mediated beta cell destruction with leading on to absolute insulin deficiency. Type 2 is either insulin deficiency or insulin resistance. Type 3 is specific type of diabetes, which could be monogenic or maturity onset diabetes of young. Here, there are genetic defects of beta cell development or function characterized by mutation due to HNF factor 4 alpha, 1 alpha, glucokinase, or there could be a mutation in the ATP sensitive potassium channels. There's transient neonatal diabetes, and the diseases due to exocrine pancreas can also lead to diabetes, like pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, and etc. Certain genetic defects in insulin action, which include type A insulin resistance, Rabson-Mendelian syndrome, lipodystrophy syndromes, can also lead to diabetes mellitus. Some endocrinopathies are also accompanied with the manifestation of diabetes mellitus, like acromegaly, Cushing syndrome, glucogonoma, pheochromocytoma, and others. Certain drugs and chemicals can induce diabetes, like excessive utilization of glucocorticoids, antipsychotics, thiazides, and many other list of drugs. Generalized infections like congenital rubella, cytomegalovirus, and Coxsackie viruses can also lead on to this disease. And some of the immune-mediated diabetes, like stiff person syndrome or anti-insulin receptor syndrome, can lead to the diabetes formation. Other genetic syndromes are also associated with complication of diabetes, like Wolfram, Down syndrome, Klinefelter, Turner's, etc. The fourth is the gestational diabetes mellitus. So coming to the pathological classification, there are 5 types: type 1, type 2, specific genetic types, gestational diabetes, and atypical diabetes. So before going into the pathophysiology of the various types, I shall discuss a few slides regarding normal glucose homeostasis and insulin biosynthesis. Regulation of glucose is itself as a tricky phenomenon in the body. Regulation of glucose itself is a tricky phenomenon in the body. It's purely by neurohumoral regulation. The organs that regulate glucose and lipids communicate by neurohumoral mechanisms with fat and muscles through adipokines, myokines, and metabolites that influence liver function. So according to this picture, as we see, whenever the blood glucose is raised by ingestion of the food, this glucose is taken up by the peripheral tissues like brain, which is insulin independent, by peripheral tissues like skeletal muscles and adipose tissues, which is insulin dependent, and liver as a bimodal action. If there is a rise in glucose, it is converted into glycogen and storage part. Whenever the blood glucose level falls, the liver itself releases hepatogluconeogenesis and glycogenolysis and add on to the blood glucose levels. During diabetic mellitus, there could be an impaired response with insulin and glucagon, where the peripheral uptake of glucose is reduced, so that these tissues, skeletal muscle and adipocytes, will go for low caloric status, which in turn trigger the appetite, leading on to polyphagia. At the same time, this low caloric status is overcome by lipolysis and proteolysis, leading on to increased free fatty acids and amino acids. And the liver, there is an increased sensitivity to glucagon, leading on to more release of glucose into the peripheral the plasma by hepatogluconeogenesis or glycogenolysis. Coming to insulin biosynthesis, insulin of more than 70 milligram per deciliter is a trigger point of insulin synthesis. The glucose of more than 70 milligram per deciliter itself is a trigger for the synthesis of insulin. The plasma glucose is taken up into the beta cells of islets of pancreas by glucose transporters, where intracellularly glucose is converted into glucose 6-phosphate through glucokinase. In the mitochondria, it is metabolized into pyruvate and release of ATPs and ADPs. This will in turn sensitize the ATP-sensitive potassium channels, leading on to efflux of the potassium, causing depolarization of the cell membrane, which in turn causes influx of calcium. Thus, calcium mobilizes the secretory granules containing insulin and C-peptides and releases the insulin hormone along with C-peptide. So measure of C-peptides is an indirect measure of the insulin release. So the points to be noted here is any conditions which lead to mutations in glucose transporters, glucokinase, or mitochondrial mutations, ATP-sensitive potassium channel mutation, or islet transcription factors mutations will lead to decreased insulin synthesis. Coming to pathogenesis and pathophysiology of type 1 diabetes, this is a disorder resulting from a chronic autoimmune destruction of insulin-producing beta cells in pancreas. It's around 3 to 5% in incidence. Polygenic in nature, involving more than 40 loci. This is a temporal model which lets know us about the time of the disease and the beta cell destruction. So you can see the genetic predisposition and the immunological trigger will lead to beta cell destruction. The staging wise, by around third stage, there could be destruction of more than 90% of the beta cells, leading on to over diabetes. So the genetic factors are HLA chromosome number 6, which codes for MHC class 2, representing the antigen to the helper T cell, is involved in immune system. HLA-DR3, HLA-DR4 halotype mutation is also involved in the establishment of diabetes type 1. Other environmental causes would be Coxsackie viral infection, rubella, environmental toxins, and all these things will lead to immune-mediated destruction of beta cells. Here, the autoantibodies are produced against the insulin islet cell cytoplasmic antigen, islet cell surface antigen, glutamic acid dehydrogenase, anti-insulin antigens. Demonstration of at least more than 2 autoantibodies will be diagnostic of type 1 diabetes mellitus. So all this immune destruction will lead to reduced insulin secretion. So the over diabetes is established when there are more than 90% of cell destruction. Coming to pathophysiology, here we can demonstrate the presence of immune-competent and accessory cell infiltrates in the pancreatic islets. We can also demonstrate the association of susceptibility to MHC class 2 and HLA. And we can demonstrate the presence of islet cell-specific antibodies. And we can also show the involvement of monokines inside CD4 T cell components. Coming to the metabolic effects in this condition on the glucose, lipids, and proteins. In type 1 diabetes, there is decreased insulin secretion, hence there is a reduced peripheral uptake, and the plasma levels are raised, plasma levels of glucose are raised, which could exceed the renal reabsorption threshold, causing glycosuria, which is osmotic in nature, leading on to polyuria, patients compromising by polydipsic symptoms. Since there is decreased peripheral uptake, there is increased lipolysis and proteolysis, leading on to increased free fatty acids and amino acids. At the same time, the glucagon is more released in type 1 diabetes. Sensitizing, there is increase in hepatic gluconeogenesis and glycogenolysis. Apart from that, there is reduced synthesis of storage of triglycerides in the adipose. Coming to pathophysiology of type 2 diabetes, it could be because of impaired insulin secretion or impaired insulin secretion action or insulin resistance. So pathogenesis here is multifactorial. It is more of multiple loci of genetic factors are involved and lifestyle is involved, and both leading on to impaired insulin secretion or insulin resistance, creating impaired glucose tolerance, leading on to type 2 diabetes and progressive hyperglycemia. So these are all various conditions where we encounter with insulin resistance, like obesity or overweight, excess glucocorticoids utilization, excess growth hormone, pregnancy, gestational diabetes, polycystic ovarian diseases, and many list of diseases could lead to development of insulin resistance. So we all know the complication of diabetes mellitus with a progressive hyperglycemia. There could be microvascular or macrovascular complications. The microvascular complications are because of protein kinase activation, increased flow of polyol pathway, increased flow of exosomal biosynthetic pathway. So we can see here the increased blood glucose levels leading on to activation of protein kinase activation, causing microvascular damage, leading on to retinopathy, neuropathy, and nephropathy, leading on to visual loss, ulcers and amputations, and renal failure in nephropathy. So the macrovascular complications because of increased synthesis of advanced glycation end products, which we call it as AGEs. So increased AGE will lead to increased endothelial dysfunction, coagulation tendency is increased, atherosclerotic formation is increased, leading on to diabetic vascular complications like peripheral vascular diseases in myocardial ischemia, infarction, and stroke. Third type is monogenic or a specific type or maturity onset diabetes of young. This is an autosomal dominant inheritance. It is due to mutation in the genetic coding as its enriched transcription factors or glucokinase. Maturity onset diabetes of young type 1 is because of HNF factor 4 alpha. HNF factor 1 alpha mutation is type 3. And type 5 is because of HNF factor 1 alpha mutation. And type 4 is a rare variant where we have a mutation of pancreaticoduodenal homeobox. The pathogenesis here is there's a glucose threshold which is set for insulin release is set higher than the normal. Neonatal diabetes, it is transient or permanent or syndromic in nature. It is based on the phenotype and the onset is within 6 months of age. Genetic mutation occurs which impact the beta cell function and the development of pancreas. Most of the times the phenotypes will also overlap with type 1 diabetes. Treatment here would be an insulin substitution itself. Certainly, sometimes ATP sensitive potassium channels mutation is identified, then they have a very good response with the sulfonylureas also. Gestational diabetes, again, it's a glucose intolerance developing during second and third trimester of pregnancy. Pathogenesis here is insulin resistance related to metabolic changes in the pregnancy. During this period, that means in the pregnancy, there is increased demand in the insulin requirement. And the recommendations regarding gestational diabetes mellitus is similar to that of an adult diabetic mellitus guidelines according to American Diabetic Association. Any pre-existing or pre-gestational diabetes are not considered to be of GDM patients. Coming to the fifth type, which is atypical diabetes mellitus. These are neither type 1 nor type 2 nor a single gene mutation like maturity onset diabetes of young. Then those are those patients which develop type 2 diabetes phenotype with before puberty, or these are type 2 diabetic phenotype in a very lean individuals. These are ketosis prone diabetic patients. And the mechanism leading to this atypical form is still under study. So these are my references. Thank you.
Thank you, Dr. Megha. Now I
Thank you.
invite Dr. Manjunath, is Professor and Head of the Department of Anesthesia at Mysore Medical College. Dr. Manjunath, please take up your topic, which is on anti-diabetic agents. Thank you.
Good evening, sir.
Good evening.
Good evening, Kodandaram, sir. Good evening,
Good
everyone.
evening. Good evening.
Shall I go ahead?
Yeah, sure. Please.
I think I'm audible and I think my slides are visible.
Yes. Yes, please go ahead.
Yeah,
Sir, can you go to the slideshow mode, sir?
it's okay now.
It's not in the slideshow mode.
Yeah, good. Okay,
Yes.
Sanish is okay.
Yes.
Yeah.
Proceed, sir.
Good evening, everyone. At the outset, I would like to thank the organizers of this webinar, Indian College of Anesthesiologists, especially Dr. Muralidhar Kanchi sir and Dr. Sanish for giving me the opportunity to speak on anti-diabetic drugs. So, disclosure, I have no financial disclosure or conflicts of interest with the presented material in this presentation. Greetings from Mysore Medical College, Mysore. And before going on to the topic anti-diabetic drugs, I would like to talk on little bit on just a little bit, just touch upon diabetic mellitus, insulin and glucose homeostasis. Madam has already dealt in detail. Just still, I just wanted to take it. So diabetes, the definition is a clinical syndrome which is characterized by hyperglycemia due to absolute or relative lack of insulin, affecting the metabolism of carbohydrates, proteins, fat, and water and electrolytes. So as Madam said, there are two types of diabetes mellitus. So one is type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1, you got absolute because of the progressive destruction of the insulin, the islets of Langerhans, we got absolute lack of insulin. And in type 2 diabetes mellitus, more of insulin resistance. So now we coming on to the insulin actions. As far as the insulin actions is concerned, insulin has got a ubiquitous and all effects on carbohydrates, proteins, fat, and water and electrolytes. These actions are classified as anabolic and anti-catabolic actions. So this this anabolic and anti divided into anabolic and anti-catabolic actions. The balance of these effects in the fasting, post-ablative states, and after food and during exercise is controlled by the relative concentrations of the blood concentration of insulin, the only anabolic hormone, and the other other hormones like several catabolic hormones like glucagon, growth hormone, cortisol, catecholamines, and thyroid hormones. So this is the actions of insulin we have to keep in mind. So as I don't want to go into the details of this glucose homeostasis, as Madam already dealt in detail. So now directly going on to the anti-diabetic agents. The anti-diabetic agents are classified as insulin and its analogs and oral hypoglycemic agents. So oral hypoglycemic agent, anti-insulin agents analogs, along with that we have got synthetic analogs also. We're going to touch upon synthetic analogs also. So now coming on to the insulin and its analogs. The first group of drugs, I would like to discuss insulin and its analogs. The immune insulin can be reproduced by recombinant DNA technology using yeast or bacteria. And the amino acid sequence of human insulin can also be altered to produce insulin analogs with a different onset and duration of action. Because insulin is a polypeptide and it is susceptible to the actions of degradation in a GIT, therefore it has to be given subcutaneous injections. Now coming on to the different types of insulins. Insulin preparations are generally divided into three major categories based on how quickly and how long they work. So first we have rapid acting insulins. So these rapid acting and rapid acting insulins fall into the group are insulin lespro, insulin aspartate, and insulin glulicin, which are considered as rapid acting, producing peak effect as quickly as 30 minutes and duration of action of about 5 hours. Another analog that belongs to this group is regular insulin, which is considered as short acting with a peak effect as quick as 2 hours and duration of action usually less than 8 hours. Now we may wonder what gives these analogs ability to act quickly. Insulin molecules naturally likes to stick together, forming a so-called exomeres. Thus, that is, the 6 insulin molecules bound together, these hormones are too large to cross from the subcutaneous tissues into the bloodstream. Therefore, they must first cleave into separate single insulin molecules to absorption to happen. So amino acid sequence can also be altered so that we can get analogs with faster absorption and more rapid onset of action. Next, we have got what is known as intermediate acting insulins. The preparation falling into this category are called as NPH insulin, also known as isofenic insulin. Unlike the rapid acting insulins, NPH insulin has a little slower onset of action and it provides a peak effect somewhere around 6 hours mark and lasts about 18 hours. These longer acting effects are accomplished simply by addition of zinc or protamine to regular insulin. which results in a complex that is less soluble, the final outcome being the delayed absorption and thus longer duration of action. Finally, we have got a longer acting insulin, so with a slower onset of action. The preparation following in this category are following. The one is the insulin detamir with a peak effect between 6 to 8 hours and duration of action up to 24 hours. The next insulin is a glargine, which does not produce a peak effect due to its steady state delivery of insulin for about 24 hours. And finally, we have got insulin degludac, which does not produce a peak effect and lasts beyond 24 hours. Again, all these effects are the results of modifications of the insulin molecules. There are some different some modifications which are, I think, modifications to reduce or to decrease the absorption of this insulin into the circulations. So to summarize, the insulin preparations are rapid-acting insulin, short-acting, intermediate-acting insulin, and long-acting insulins. So there are some synthetic insulins also available in the market. So what is the synthetic injectable analogs are also available. The synthetic injection in the analogs are synthetic amylin. What is amylin? The pancreatic beta cells not only secrete insulin, but also secrete another peptide hormone called amylin. The function of the amylin is to delay gastric emptying, to suppress the postprandial secretion of glucagon, and to also promote satiety. The only amylin which is available in the market is pramlintide. The advantage of this pramlintide is it allows the insulin doses to be reduced, and there is always the risk of hypoglycemia and nausea and vomiting and weight loss. So the last group of injectable analogs are incretin mimetics. So I'm going to talk about these incretin mimicals in detail, as for detail whenever you go for oral hypoglycemic agents. Just what are these incretins? These incretins are a group of metabolic hormones that are secreted from the gastrointestinal tract in response to food ingestion, and their function is to stimulate the pancreas to produce more insulin. The two primary incretins are GLP-1 and GIP. The GLP-1 is nothing but glucagon-like peptide 1, and the second one is a glucose-dependent insulinotropic polypeptide. These concentration of these hormone would benefit in the diabetic mellitus patients. However, the actions of these GLP and GIP are very short-acting because the DPP4 enzyme, that is called dipeptidase 4 in the enzyme, that will going to inhibit this GLP-1 and GIP, so that the secretions of so that this glucose will be definitely decreased. So the GLP-1 and GIP are the incretins which will going to increase the secretions of they'll going to help in the diabetic patients. Now comes the oral hypoglycemic agents. There are many oral hypoglycemic agents available in the market. So there are these oral hypoglycemic agents. The pronunciation is difficult, and they are similar in pronunciation and very difficult to remember. So we have got, so one is the sulfonylurea drugs, the second one is the meglitinides, and third one is the thiazolidine diones, and the fourth one is biguanides, and the next one is the alpha-glucosidase inhibitors, incretin agonist, DPP4 inhibitors, and the SGLT inhibitors. SGLT inhibitors, nothing but sodium glucose transport inhibitors. These categories are chemically different, and their common goal is to reduce blood glucose level, especially in type 2 diabetes mellitus. So coming on to that, these drugs are chemically different and pronunciation difficult, very difficult to remember these things. So now remembering which type of drug and which category it belongs is very difficult. So we have got some suffixes, common prefix and suffixes are attached to this oral hypoglycemic agents. The easy mnemonic way is sulfonylureas have got a prefix called GLI. This suffix will be prefix will be there in all sulfonylureas. There are some other drugs also possible. They can use this GLI between infix or suffix, but always the GLI will be the prefix for sulfonylureas. The second one will be the meglitinides. This meglitinides has got a glycine as a suffix. So they also have the chemically different, but they act like sulfonylureas. They are also sulfonylureas drug like meglitinides. The third one is the thiazolidine diones. They end with the suffix glitazone. And the biguanides, formine. And the alpha glucosidase inhibitors like OS. and incretin agonists, they got a suffix or glutide. And DPP inhibitors have got a suffix gliptin, and SGLT inhibitors have got a suffix called glyphosine. So it is easy way to remember. So these are the prefix and suffixes for oral hypoglycemic agents. Now we're coming on to the each drugs, especially the sulfur, each drugs and the mechanism of action of each drug in detail. So let us go to the sulfonylurea drugs. These sulfonylurea drugs are using the prefix GLI. With prefix GLI, we can identify that all these drugs are belong to the sulfonylureas. These sulfonylureas are classified as first generation sulfonylureas and second generation sulfonylureas. We have the first generation sulfonylureas such as talbutamide, chlorpropamide, and tolozolamide, and acetohexamide. And these drugs end with this does not end with the GI. The prefix does not. There is no prefix for GLI. They end with the suffix amide. These first generation sulfonylureas produce hepatotoxicity. That is why nowadays they are not preferred. So we have the second generation sulfonylureas drugs. That is glipizide, glycoside, glibenclamide, and glimepiride. These drugs have the prefix GLI. So these all have the prefix GLI and here are the glibenclamide, which can also be considered as a glyburide. These drugs are mainly affecting the pancreas. They can increase the release of insulin from the pancreas, and when the insulin is released, it can control the blood glucose levels. So you should know what is meant by the glucose dependent insulin secretions to know the mechanism of action of these sulfonylureas. As Madam already told, these sulfonylureas are potassium channel blockers. So they act on these potassium channel blockers to increase the insulin secretions. So there's a second group of drugs are glinides, which are sulfonylurea like antidiabetic agents. So they have got the suffix glinide. So they have the drugs like ripaglinide, so nitaglinide. These drugs are they are chemically different. They act similarly to the sulfonylureas, which can increase the release of insulin and which control the glucose levels. The third group of drugs is the thiazolidinediones with the suffix glitazone. So we have got drugs like pioglitazone, rosiglitazone, and troliglitazone. All these are thiazolidine diuretic. These drugs act on adipose tissues. The unique mechanism of action is they are going to promote the actions of PPAR gamma receptors. This PPAR gamma receptor, nothing but they are peroxisome proliferator activator receptor gamma, which is a nuclear protein which is involved in the synthesis of protein. These protein level which controls the glucose levels with the help of transcription of glucose. They can also increase the uptake of glucose in the adipose tissue, as well as they can also affect the liver. So they can reduce the hepatic glucose production. By all of these, they can increase the insulin sensitivity, but they are not increase the insulin secretion directly from the pancreatic cells. The fourth one is the bicarbonate. They have the suffix formin. So the what do you call metformin? Everyone know about metformin drugs. This is the first drug that is indicated in the early stage of diabetes because this drug can reduce the body weight as well as it can control the blood glucose levels. So this drug mainly affects the liver and inhibits the few of the enzymes which are produce hepatic glucose production so that it can reduce the hepatic glucose production. The fifth one is the incretin agonist. As I said earlier, these are the incretins are the metabolic hormones which are secreted in the GIT with the ingestion of glucose. They have having the suffix glitide or a glutide. It's called a glutide. So there are a lot of we have to go slowly because the pronunciation is totally different. We have got the liraglutide, dulaglutide, albiglutide, and the albiglutide. But we have few other drugs in this category with different suffixes like exenatide, the exenatide and lexenatide. It's called a tide. The suffix have got a tide instead of glutide. These two drugs are derived from non-human peptides, so they have got a different suffix. These incretin agonists mainly act on pancreas and affect the gastric system, like delaying the gastric emptying time, and they also act on the brain. So they also act on the brain so that so the appetite will be decreased. So they can produce some sort of weight loss in this patient who are taking these drugs. The fifth one is the DPP4 inhibitors. That is called dipeptidyl peptidase inhibitors. These are having the suffix gliptin. So example, sitagliptin and sexagliptin, linagliptin, linagliptin and algoliptin. These are mainly inhibiting the metabolism of incretins, so that incretins are more secreted and they can affect pancreas, gastrointestinal system, as well as brain to control the blood glucose levels. Seventh one is the SGLT inhibitors, that is glucose transport, sodium glucose transport inhibitors. They have the suffix glyphosine. These are the drugs imagliflozin, dapagliflozin, and enagliflozin. These drugs mainly affect the glucose absorption at the renal tubules. So the glucose as well as the sodiums are also going to be reabsorbed into the systemic circulation from the apical membrane of proximal convoluted tubules of the renal tubules. These SGLT transports are going to be inhibited by these drugs. So because of this inhibition of these drugs, the sodium and glucose are not absorbed. So they are secreted in the urine. In this way, SGLT inhibitor reduce the blood glucose level by inhibiting the glucose absorption. The last one of this anti-diabetic agents are eighth one is the alpha glucosidase inhibitors. These alpha glucosidase have the suffix os like acarbose and oglibose, and the different one suffix is meglitol. All these are alpha glucosidase inhibitors. These drugs inhibit alpha glucosidase enzyme, which is responsible for cleavage of glucose from the carbohydrate, so that they can inhibit absorption of glucose into the systemic circulation. In this way, we have got 8 categories of anti-diabetic agents, which can easily identified by the suffix and prefix. Thank you.
Thank you, Dr.
Thank you,
Manjunath.
Dr. Manjunath. It was very concise and precise, and the mnemonics were very useful. Thank you very much.
Yeah, I invite our next speaker, Dr. Harsoor. He is going to talk on anesthesia for patients with the diabetes mellitus. Dr. Harsoor is a professor and head of the Department of Anesthesia, Dr. B.R. Ambedkar Medical College, Bangalore. Over to Dr. Harsoor.
Yeah, thank you very much, sir. Good evening, all my colleagues. My respects and greetings to the ICA and the chairman, Dr. B.R. Radhakrishnan, Dr. Sanish, and also Dr. Muralidhar, who is involving me into this program. Thank you, everyone. And to that extent, Dr. Megha and Manjunath have made my job easier. I'm just one second. I'm going to speak on the topic anesthesia for diabetic patients. There are no conflict of interest to be declared from my end. I'll straight away begin with the preoperative evaluation of these patients. It is very, very essential and important that a detailed history must be elicited with regard to the age of the patient, and the effort tolerance is the one which is very important in these cases. And also is the duration of their disease, the past and the current treatment of their disease, what the patient is getting, the frequency and the severity, and the etiology of any complications. If the patient has suffered from any complications like ketoacidosis or hypoglycemic events, if he or she has got, so that must be elicited because they are going to help us in the management. And finally, the important thing is, what is the type of surgery? Is it a routine intermediate type of a surgery or major surgery like cardiac or the neuro procedures? And also, it is important to note whether there are any history suggestive of a peripheral or autonomic neuropathy. The gastroparesis is another thing that is very common in these patients. And these patients may be also having atherosclerosis, hypertension, and congestive cardiac failure. All are attributable to the diabetes and its associated symptoms. And so therefore, these patients may be on a beta blockers many times, which because we need to continue these drugs, we should know whether the patient is on such drugs and whether the patient is having any altered renal functions or any other symptoms that are relevant to the cardiac, renal, or retinal, neurological, peripheral vascular. All these things, whether they are important or not, it is essential that we elicit this history document it properly, inform the patient, and wherever it is possible, we must optimize these situations. Coming to the physical examination, remember, this is a very, very strong statement always made. Diabetes is not a disease, but it is mother of all diseases. So it can affect any and every organ in the body. That is a very important thing we must remember when we are dealing with a patient with the diabetes. So therefore, a detailed whole body examination is very, very important. And as an anesthesiologist, I'll be focusing my examination, in addition to the general examination, is about the airway, the cardiovascular system, including the peripheral vascular diseases, central nervous system, including the peripheral and the autonomic nervous system, and the renal and the gastrointestinal system also, to some extent, we should know it. And whether the patient is having the chronic hyperglycemia, because these patients, if there is a hyperglycemia, there is a non-enzymatic glycosylation of the collagen tissues, especially in the joints like temporomandibular joint or oculotaxillary joint, or even the spines. So what happens is the limited joint, the neck movements, which I'm very much interested when we are doing securing the airway or intubation. And for that, I'll not go into the details of what is a prayer sign or a palm print test. These tests are absolutely necessary, and definitely they will give an indication regarding the cervical spine mobility and the possibility of a difficult intubation also. So it is a very, very important test. And also assess the preoperative autonomic neuropathy, anything is there. Because one important thing, that is heart rate variability in response to either a deep breathing or the Valsalva maneuver, is one of the excellent indicators of any autonomic neuropathy. Because here the incidence of perioperative dysrhythmias are pretty high, or the patient may develop silent MID intraoperatively or in the perioperative period. So the patient's ability to compensate for hypovolemia or hypotension is very, very vital for us, because the compensatory tachycardia or the increased peripheral resistance, which is normally seen in otherwise non-diabetic patients, will be absent in these patients. So we should be careful whether such a thing exists by our preoperative examination. And if the patients are already on ACE inhibitors, and these are the patients who pose the risk of post-induction hypotension. Soon after the induction, they may go into the hypotension. So therefore, they will be cautioning us with regard to the slower induction, and also, if necessary, the use of vasopressors. So we should be ready with those things. And the renal impairment is indicated by the presence of glycosuria or the dehydration. So therefore, it is very, very essential that after the detailed examination and the physical examination, whatever is possible, we can optimize these patients. And the optimization is mainly focused on these three things. Well, there is one, whether we can use supplemental insulin, or anything we can do with regard to the difficult intubation. And then finally, one important question is what level we need to optimize the blood sugar level. So under these three headings, I'll be talking. So first and the foremost, whether the supplemental insulin is required. Yes, if the patient, like Dr. Manjunath, is several drugs, oral antidiabetic drugs he has mentioned, and if patient is on some of these drugs, like say, for example, metformin, we need to stop at least 48 to 72 hours before the surgery, because the possibility of a lactic acidosis is high if this drug is continued. And a very popular drug, sitagliptin, currently used, need to be discontinued preoperatively because the possibility of hypoglycemia is high. And currently fancy drug like SGLT2 inhibitors, it is recommended that almost 6 weeks of the stopping this drug is definitely beneficial, because this is one drug which is identified with the euglycemic decay, and which is often difficult to detect intraoperatively. So such a drugs, if the patient is on, these drugs need to be stopped. And next most important thing is about the effort tolerance. If we can elicit the history by way of the patient's profession or household, domestic work, anything, if it is possible to elicit, well and good. Otherwise, probably a stress testing may be necessary in these patients. And ECG monitoring and recording is required, because whenever there is a possibility of autonomic neuropathy is there. So this will be very much helpful to us. And remember the preoperative use of insulin along with the dextrose. Even when the blood glucose levels are normal, they may be beneficial, because it is observed that low incidence of a peripheral insulin resistance and risk of a surgery-induced stress is minimized with this practice of using preoperative insulin with the dextrose. So maybe that is a very beneficial one. And the stress of surgery is quite strong, and because it produces elevated sympathetic tone, and thereby there is impaired release of the catecholamines, the glucagon, or even the cortisol. All of these drugs, all of these endogenous peptides are likely to increase the serum glucose levels. So therefore, supplemental insulin in the perioperative period is very much essential and also helpful. With regard to the anesthetic drugs, by and large, they affect the glucose metabolism through the modulation of a sympathetic tone only and not directly. If the sympathetic tone is increased, then that may be possibility of hyperglycemia. And inhalational agents, majority of them, they suppress the insulin secretion and leading to glucose dysregulation, and they are the hyperglycemia. And another factor during intraoperatively, what we need to remember is hypothermia, because this can lead to peripheral insulin resistance, hyperglycemia, and long-term effects like a decreased wound healing or the infection will be possible. Whenever there is a acidosis, the pH of around 7 or 7.5, it is well known that respiratory and myocardial depression can occur. So the patients with the type 1 diabetes are predisposed to developing the ketoacidosis during the periods of major stress should be kept in mind. So this is where the supplemental insulin in the perioperative period is very, very essential. And we can use the ABG analysis to know both the serum glucose levels as well as the pH levels. And the second point, what I was telling, so the difficult intubation, which is anesthesiologist domain exclusively, and an observation about the HbA1c value, which should be, if it is preferably less than 6, it should be ideal, but many times it will not be so. Because of the glycosylation, as I said earlier, there will be limited TMJ movements or the C-spine movements. So this we will end up in a difficult visualization of the glottis. So therefore, we must be always prepared for either for the awake intubation or things like a fiber optic intubation wherever it is possible. And if the patients are known to be having a gastroparesis, even we should be prepared to do a rapid sequence intubation. And with regard to the optimum blood glucose levels, this is another statement. There is no agreement among the anesthesiology community exactly what is the standard preoperative blood glucose levels. And this is more so it is applicable for routine, minor, and the intermediate risk surgeries. And of course, high risk surgeries, there'll be like cardiac and the neuro procedures may be coming under the different category. But there is a consensus with regard to the blood glucose levels below 180 or 150 to 180 is acceptable. That's what the majority of the anesthesiologists say. Because what the tests, the published literature says is any blood glucose level less than 110 milligrams or 110 to 150, or it is less than 220 milligrams. All these blood glucose levels have not shown any difference in the postoperative morbidity or mortality. So hence, there is anything up to 180 milligrams should be acceptable. This is my view whenever we are dealing with the case of a diabetes mellitus. So coming to the pre-medication, apprehensive patient, yes, naturally the serum blood glucose levels are likely to go up. So anti-anxiety drugs like midazolam are necessary. And pain of any origin, if the patient is coming for a surgery either because of the trauma or the visceral pain, opiates definitely will be essential and beneficial. And prokinetics like metoclopramide because of the gastroparesis will be helpful, and also the H2 blockers, they are also equally useful. And monitoring is concerned, I'll not go deep into that because my colleague is going to deal with it. But however, we should keep in mind the associated comorbidities. That is like atherosclerosis or autonomic dysfunction, and even the other metabolic abnormalities, which can be indirectly detected by this. Because these patients will be having higher incidence of the infection or the metabolic abnormalities when compared to the non-diabetic patients. But however, the routine investigations like ECG, because these diabetic patients are at a higher risk of a silent myocardial infarction or development of a congestive heart failure. So ECG is very, very essential. Other routine monitors like SpO2, EtCO2, or NIBP and temperature monitoring, as I said earlier, they are essential because they will have impact on the management of these patients and the blood glucose maintenance. And if it is indicated, the arterial cannulation also will be beneficial. What we need to do in the intraoperative period after having this, when I told you about the surgical stress, but the stress of anesthesia is much smaller when compared to the surgical stress. So these stress hormones, what I said earlier, glucagon, cortisol, or catecholamines, they may induce the hepatic gluconeogenesis along with the greater synthesis and breakdown of triglycerides. So therefore, these stress of anesthesia should not be a major factor when compared to the surgical stress. And pre-medical drugs like benzodiazepines and some of the induction drugs, though they are described to be theoretically blocking the secretion of the cortisol, their implication in a clinical practice is considered to be much, much less. But however, what we need to remember is intraoperatively, wherever it is possible, try to avoid the laryngoscopy or tracheal intubation-induced stress, like prolonged intubation or intubation under the lighter planes of anesthesia, or the maintenance of the lighter planes of anesthesia, and any inadvertent hypercarbia, because all these things may increase or the management of a blood glucose level may be different or difficult. As I said earlier, there is a consensus with regard to the blood glucose levels at 180 levels. So whenever there is a hyperglycemia, we need to manage that with the intravenous insulin, or if there is a hypoglycemia below 110 milligrams is there, that also must be treated with the administration of the 50% glucose or whatever practice we use in our institution. But what is important is in these patients, hourly blood glucose monitoring, that is the one which is very, very critical to avoid both the hyperglycemia or the very serious hypoglycemia events. And if it is possible, an arterial sample is better. If it is not, even the capillary blood also will do. Because you know the hyper and the hypoglycemia, especially the hypoglycemia with organ ischemia, may lead to the problems like MI and the cardiovascular accidents. So we, at any cost, the hypoglycemia must be avoided. Can we use regional anesthesia? The answer is yes, because the regional blocks or the neuraxial blocks mitigate the stress-induced hyperglycemia. Definitely, that is a one answer. And if the patients are apprehensive with regard to the regional anesthesia, a thorough counseling is very, very beneficial. And remember, peripheral neuropathy is not a contraindication, but what is essential is documentation and then informing the patient about the existing neuropathy and the disorders. But whatever we can do is use of ultrasonography, and if it is possible, even the peripheral nerve stimulators to prevent the further nerve injury may be beneficial. And of course, needless to say, the aseptic precautions are must whenever we are using regional anesthesia. And a couple of slides about the emergency surgeries. What I'm not going to go deep into this, but however, there are two indications. One is a trauma and other one is a severe infection. These are the two situations where emergency surgeries may be necessary. And both these things may lead to metabolic decompensation like dehydration, decay, or electrolyte disturbances. And remember, whenever there is a life-threatening emergency, do not wait for the normalization of metabolic indicators, and we can straight away proceed, and then intraoperative correction of metabolic disorders is suggested, because these disorders are known to cause dysrhythmias and hypotension. And as I said earlier, the hyperglycemia, we need to deal with it. Other things are dehydration, acidosis, and the potassium correction. These are the four things we need to deal with in emergency situation. That is the hyperglycemia, you must bring it down with the use of insulin. And if it is a dehydration, there is a correction should be done slowly. But one factor that I would like to stress upon is acidosis may be multifactorial, or it may be we need to find out the reason. And what is important is rapid correction with the soda bicarb should be discouraged wherever possible, because it is known to cause structural or the functional changes in the central nervous system. And another factor we should remember is elevated plasma acetone with the ketonuria may continue even for 24 to 48 hours after both the metabolic correction of sugar and other acidosis is corrected. So therefore, ketonuria merely is not an indication that we must continue the treatment. So we must be careful about that one. And also another one is about the hyperkalemia. I'm not going to deal with this because my next speaker is going to talk in detail about this. So this is another condition also where the half normal saline may be used to treat the hyperosmolar hyperglycemic syndrome. So that way we need to deal with all the emergencies without waiting to correct it. Otherwise we may do more damage. And the last thing about the postoperative analgesia, as I told earlier, regional nerve blocks are always superior to parenteral systemic analgesic in managing the pain. And regional blocks or the neuraxial blocks mitigate the stress-induced hyperglycemia. Hence, the good control of blood sugar is possible with the regional nerve block. So thank you very much for giving me this opportunity.
Thank you very much, Dr. Harsoor, sir, for elaborative talk on anesthetic consideration for patients with the diabetic mellitus. Thank you. Thank you. Yeah.
Thank you very much. I think Dr. Mohanty is not available. So it's my great pleasure and privilege to introduce Dr. Sripada Ji Mehandale, who is the professor and HOD at the Department of Anesthesiology and Critical Care at KSHEMA Medical Academy in Bangalore. He is very well known for his technical skills and knowledge base. And it's a distinct pleasure for me to invite him. And his areas of interest include airway, regional anesthesia, and the cardiac life support training. And he has been quiz master for several anesthesiology quiz events at various levels. And he has several publications. And he has been awarded the best reviewer of IJA 2017. Very nice. Thank you, Sripada. We are looking forward to your talk on the monitoring and management of diabetes based on the monitoring. Thank you so much.
Thank you, Muralidhar sir, for this opportunity and this elaborate introduction. I also thank ICA and Dr. Shanish and all of you for giving me this wonderful opportunity to be here with all tall statured guys in the field of anesthesiology. Thank you so much. And greetings from KSHEMA Medical Academy, fondly known as KSHEMA under NITE deemed University at Delakatta, Mangalore. I welcome you to visit our place whenever it is possible. Moving on to perioperative monitoring and management of diabetes mellitus in the operative setting, I have nothing to disclose, but I can only say that I may not be able to cover the topic in entirety because of the time factor. Will try my best to cover it. I'm going to discuss what are the concerns in the perioperative setting and the monitoring, then intraoperative and postoperative complications in brief and how to manage them, and a bit about how to and what to take home message. My job was made easy by Harsoor sir, who was my teacher during my graduate days. I am very happy to sit with him and have a lecture together. Thank you so much, sir, for teaching us during your days.
Thank you very much.
As already it was elaborated, autonomic neuropathy is one of the important concerns in a patient who is coming to get anesthetized. Unfortunately, many times autonomic neuropathy is either not diagnosed, it is subclinical, and then we have to look for it, and the residents may be little wary because the tests are little not so easy to conduct for them. Then there is hypo or hyperglycemia perioperatively, effect of anesthesia on blood sugar, effect of surgery on blood sugar. All these factors already been discussed to some extent. And then effect of blood sugar on anesthesia, which is a small topic yet. Then a few words about the other issues. Coming to autonomic neuropathy, it is very easy to diagnose if one looks into these symptoms. Very easy. Patient has a history of numbness or pain in the leg, resting pain, especially tingling, burning pain, or onset of cramps. Distal weakness of limbs. Say patients after walking few yards, I get tired in the legs and like that. And patient may have ischemic changes, but no complaints of ischemia anytime. That is indicative of neuropathic heart. So one has to be really worried, or any other symptoms or signs of peripheral vascular disease, whether you look into the small microangiopathy or macroangiopathy, and most importantly, what we can look for in the history is gastrointestinal tract and urinary symptoms, early satiety or alternate loose motion and descent, constipation, problems with the urination, all these things. Most important thing of this relevant to us is the cardiac autonomic neuropathy and respiratory implications of that. In a cardiac system, what happens? Cardiac system is balanced by two things. One is a sympathetic system, other one is a parasympathetic system. When there is imbalance between these two systems in autonomic part of the body, there is a imbalance, and the response to the stimulus from outside is not graded, or it may be unpredictable. So we have lot of possible complication in these patients, like patient may have arrhythmias, ischemia or infarction, and ischemia infarction without even giving a warning sign. There may be hypertension, of course hypertension is very common, and heart failure. Often these conditions remain undiagnosed due to the denervation of the myocardium and the vascular structures. Therefore, these patients will have less response to the altered blood sugar levels, whether it's hyperglycemia, which is less dangerous than hypoglycemia. Hypoglycemia normally gives rise to various symptoms like feeling of weakness, sweating, palpitations, cold clammy peripheries, and so on and so forth. But under anesthesia, many of these signs either they don't manifest, or because of autonomic neuropathy, they cannot manifest. So there's a big problem in diagnosing the decrease in blood sugar and its complications. Then there is no response or altered response to blood loss or hypovolemia of any reason. Then comes the exaggerated response to anesthetics. As we all know that anesthetics are protoplasmic poisons, and in certain doses, they help us. While they exceed the dose, they cause problems. However, in diabetic patients, this response may be literally exaggerated, and even a small dose of propofol may end up having patient in hypotension, which normally happens in very elderly or frail patients. But young, healthy looking adult diabetics, they also have these problems. Then altered response to vasopressor and inotropes, obviously we can understand, because of the denervation of the system, there will be hyperregulation or downregulation of the receptors, and the responses cannot be gauged. So it is difficult to titrate, and we need to be really careful during titrating the inotropes. Coming to respiratory system, it has got impaired breathing control just because of the neuropathy, and these patients may have sleep apnea syndrome, which is often undiagnosed. In case of obstructive sleep apnea, it is easy to make out because the partner of the patient can complain, or even the patient himself have manifestations of the sleep apnea when it is serious. However, in these patients, that is not so common because it is all hidden. So when anesthetics work on this respiratory center, we realize that patient is having hyperventilation, and find out the reason is their diabetes. Therefore, we need to be really vigilant throughout the procedure and postoperatively about the possibility of respiratory depression among these patients and respiratory obstruction as well. Then Dr. Manjunath told us about the gluconeogenesis, blood sugar level regulation, and how the hormones pitch in to maintain the normal blood sugar level. During surgery, which is a stress for the body, which is actually we are causing homeostatic disability, instability, causes release of these counter regulatory hormones, which are actually pro-gluconeogenic, and it's a lot of glucose is produced because of insulin inhibition and other hormones which are pro-gluconeogenic. So blood sugar rises, free fatty acid rises, there is hypoglycemia, and injury to the myocardium, mitochondrium, endothelium, immune dysregulation, and superoxide generation, in the end leading to damage to the body, and it has got long-term consequences. Therefore, it is our concern to regulate the blood sugar level during the surgery. Dr. Harsoor, sir, told already about the advantage of regional techniques because they reduce the secretion of catecholamines and other hormones which are hyperglycemic, whereas volatile agents themselves can actually increase the blood sugar. Therefore, it is always advisable to use regional techniques as and when they are feasible, and also monitor the blood glucose level closely during the procedures. But many times it may not be possible to do surgeries only under regional techniques, so general anesthesia is required. A combination of regional and general anesthesia is still better because it reduces the stress response to great extent to the surgical stimulus. However, we also need to remember that the combined effect of autonomic neuropathy and the denervation secondary to the regional techniques while we manage these patients. Therefore, close monitoring is the call of the time, call of the hour. Therefore, routine monitoring, of course, pulse oximetry, ECG, and blood pressure monitoring is very essential for all cases. That has to be more closely done in these patients. And if the patient has got significant neuropathy and if you expect a lot of fluid shifts or blood loss, it is better to have invasive monitoring of blood pressure, because these patients, you don't get signs and symptoms of hypovolemia like tachycardia or lowered pulse pressure. This denervation is there. All of a sudden, after a few moments of blood loss, you may see patient sinking without much warning. And other thing already highlighted was the temperature dysregulation, and these patients are prone for hypothermia, and all the more the hypothermia can complicate the situation in the postoperative and intraoperative period. Therefore, take care the patient to be kept warm and temperature is monitored. Other important parameter which can give us a lot of ideas is the urine output. Urine output can also increase if there is hyperglycemia, and it also gives an opportunity to test for the ketone bodies. But nowadays that is not advocated. Ketone bodies, if at all you want to measure, you have to measure in the blood. Then comes the monitoring of the blood sugar. And the frequently asked question is, what should be the blood level during the perioperative period, and how frequently we should look into this blood sugar levels. A lot of studies have been done regarding the perioperative blood sugar management. Finally, the answer is we should have not so tight control, because tight control causes its own problems, especially due to hypoglycemia. So ideally, it is 140 to 180 140 to 180 milligrams per deciliter of blood sugar level to be maintained perioperatively and postoperatively. Some studies do advocate anything above 110 is fine, and definitely not more than 200 is permissible. More than 250 causes the rates of complication more than 6 times increase in the rate. Therefore, it is definitely advisable to maintain blood sugar in this range. How frequently monitor? The monitoring frequency depends on whether you use insulin perioperatively or don't use. At least every second hourly it has to be monitored. And one interesting study has told by Carlson et al. That significant duration of both hypo and hyperglycemia was detected in high proportion of patients, particularly in patients with diabetes, despite protocolized perioperative diabetes management. So this emphasizes the repeated measurements requirement in case of diabetics. Then what kind of insulin you want to use? It is simple, plain insulin or insulin analogs can be used, because the advantage of insulin analogs is they don't cause a sudden hypoglycemia, and also short-acting analogs have got a duration of half an hour to 120 minutes of duration, and because of the short duration of action, the corrective measures are easy to take. Various ways you can administer insulin: infusion or intermittent dose. Intermittent dose can be given subcutaneously also, which has got a better action profile, because slower onset, steady state of action, and reasonably good duration of action. Nowadays, we have glargine or detamir available. So a patient is already on it. It is easy to give 80% of the usual dose in a regular time. If you are using NPH or 70-30 insulin, can have 50% of the usual dose. if the blood sugar is 120 milligram per deciliter, hold for sugar if it's less than that. You can also hold back Lispo and other agents which are longer acting. Advantage of short acting subcutaneous is if you inject once in 4 hours, that is sufficient, and check sugar every second hourly. Intravenous you have to give continuously, and also the checking should be more frequently hourly. This is how you can manage the insulin in emergency surgeries. I'm not going to elaborate because of the time, but only thing you need to remember is one thing: sugar has to be maintained below 180 milligrams, but don't go for a very tight control. Frequently check the blood sugar. Use insulin infusion algorithms which are available. But if a patient is not critically ill or anticipated hemodynamic changes are not great and duration of surgery is less than 4 hours, go for a subcutaneous insulin. Monitor second hourly and follow subcutaneous dosing schedule. And a factor of 100 has to be remembered. Factor of 100 and 150 to be remembered. Generally use factor of 100. Divide blood sugar by 100 and use so many units of insulin. That is a very simple scale. And use of insulin and dextrose combination is a good thing because it provides for basal insulin requirement as well as dextrose, thereby reducing chance of ketoacidosis. Here is another scale available. It is simply divided in normal usual patient and patients who are other extremes like they are aged more than 70 years, GFR less than 45 ml per minute, because the metabolism of insulin depends on kidneys. In these patients, insulin have a longer duration of action, so there we need to taper the dose. Whereas the other extreme, there are people who are resistant to insulin, where we have to give higher dose. There's a BMI is more, they are on steroids, and daily requirements more than 80 units. All these patients we have to give more insulin. I'm not going to elaborate again, but it's a rough guide there. Then some questions about the nutrition in the perioperative period. ICU has got another aspect in this. However, it is simple to remember that for 24 to 48 hours of fasting, there's no need for nutrition in the form of dextrose. But if it is longer surgery and major surgery, we expect to keep the patient fasting. Low calorie diet like 25 to 30 calories per day per kg is sufficient to maintain euglycemia, at the same time prevent hypoglycemias. To conclude, before the conclusion, I have a small word about intraoperative decay. Most of the times in our practice, we don't use insulin perioperatively. No insulin, no glucose is the normal regime, though in the exams often PGs are made to, residents are made to say that we use Albertis, this, that regime. But actually speaking, most of the places, we don't use insulin perioperatively. This is not a very good thing because these patients are prone for hyperglycemia, as already mentioned in the research, because even if the protocolized management there is hyperglycemia, therefore it is always better to use a small dose of insulin perioperatively and have a close monitoring. Thereby we can prevent DKA, and if DKA happens, it is difficult to identify. Often we end up having a patient who is not recovered from anesthesia, and look for causes, we realized the patient is in DKA. Therefore, detecting decay is difficult. Second, treating decay is more difficult during highly stressful periods because the response to insulin is very reduced. And we have to consider these patients as insulin resistant type, and you have to treat. Other problem is if the patient is new to insulin, the response may be very serious and there may be hypoglycemia when the sugar starts dropping. Therefore, it's always better to prevent decay and treat aggressively. To conclude, patient characteristics and surgical procedure determine insulin therapy, whether you give SC or intravenous. Always target blood sugar levels between 140 to 180 milligrams per deciliter. Don't be very aggressive for tight control. It is very counterproductive. And liberal hyperglycemia is also not good. And frequent blood sugar measurements are call of the day. Always beware of hypoglycemia and very close monitoring of the patient, especially ECG, heart rate, and blood pressure are very important because their responses are unexpected. Silent myocardial ischemia, arrhythmia is very common, and also keep a watch on their urine output. And thank you very much for patient listening. I again thank everybody for the listening as well as for this opportunity. Thank you so much.
Thank you, Dr. Sripada Mehandale, for that excellent talk on monitoring and management of diabetes intraoperatively. Very well done. Please stay back till the end because we will be having questions and answers at the end of the session. And I take immense pleasure to invite Professor Manjunath AC, the Professor of Anesthesiology at Saptagiri Institute of Medical Sciences and Research in Bangalore. I request Dr. Manjunath to start his presentation on acute diabetes emergencies. He is also a well-known and accomplished anesthesiologist in Bangalore.
Yeah, thank you, sir. Hope you can hear me.
Yes, we can hear.
Audible, sir? Yeah,
yes, yes.
Thank you, sir. I thank the organizers, ICA and Muralidhar, sir, for giving me an opportunity to say a few words here. I am Dr. Manjunath, Professor from Saptagiri Institute of Medical Sciences, Bangalore. And warm greetings from the Saptagiri Medical College. Thank you, sir. I'll be talking about acute diabetic emergencies and no conflict of interest. So, namely, the acute emergencies are, we can namely five. The well-known is a diabetic ketoacidosis, hyperosmolar hyperglycemic state, and euglycemic diabetic ketoacidosis, hyperglycemia without acidosis, and hypoglycemia. These are the emergencies, diabetic emergencies we encounter in the patients with diabetes, long-standing diabetes. So just to know what is this one slide to show the primary actions of the insulin, the causes of common diabetic emergencies, and how we diagnose it, and what is the treatment. Just one slide to show the major actions of insulin. What insulin does, it drives glucose into the cell. And it also drives potassium into the cells. So it is an anabolic. It blocks the breakdown of fats. It blocks the breakdown of proteins. All these things are reversed in case of the diabetic ketoacidosis or the acute complications. First, I'll be talking about diabetic ketoacidosis. Diabetic ketoacidosis is an acute metabolic complication of diabetes. It can be seen in both type 1 and type 2. It mainly consists of a triad of hyperglycemia, the increased glucose, increased ketone bodies ketonemia, and a high anion gap metabolic acidosis. What causes this one? The precipitating factors in diabetic patients is, one is inadequate insulin therapy, or there is a lack of insulin in the body or blood, and the presence of infection. The other factors may also contribute, like myocardial infarction, cerebrovascular accidents, pulmonary embolism, pancreatitis, and alcohol. So, pathogen is how it leads to a diabetic ketoacidosis. The reduced net effective action of circulating insulin as a result of decreased insulin secretion. First of all, there is a lack of insulin in blood. And same time, when insulin is decreased, the counter-regulatory hormones are increased, like glucagon, catecholamines, cortisol, and growth hormone. And the dehydration and electrolyte abnormalities also contribute to diabetic ketoacidosis. And it is also characterized by increased gluconeogenesis, lipolysis, ketogenesis, and decreased glycolysis. So what causes hyperglycemia? There is increased gluconeogenesis. There is production of glucose is increased, and glycogen is broken down, increased glycogenolysis, and decreased glucose utilization by peripheral tissues. So the production is more, the glucose is not being utilized. This leads to increased blood level of glucose. The insulinopenia or lack of insulin, this can be absolute or relative. Most of the times in DK, it is absolute lack of insulin. And elevated cortisol, which causes proteolysis. And as a result of proteolysis, amino acids are produced. And these are also, amino acids are also forms the substrates for gluconeogenesis. And muscle glycogen is broken down to lactic acid. And this also leads to gluconeogenesis. The increased level of counter hormones will lead to the enzymes that are activation of the enzymes that are in the gluconeogenic pathway. And this also contributes for gluconeogenesis. And decreased glucose utilization is further exaggerated by increased levels of circulatory catecholamines and free fatty acids. And the ketogenesis results from the free fatty acids that are produced during breaking down of triglycerides. These are the raw materials for the production of ketone bodies. The increased production of ketone bodies, mainly beta hydroxybutyrate and astatic acid, leads to increased ketone body levels, that's ketonemia. The ketonemia is further maintained by reduced liver clearance. There is already increased production and the clearance is also decreased. Both of this leads to increased ketone body levels in the blood. The normally the buffers, both extracellular and intracellular buffers, neutralize the hydrogen ions produced during hydrolysis of keto acids. When the production is more than the body's capacity to buffer it, the anion gap metabolic acidosis results. The drugs, some drugs also may play a role in actually worsening the mainly DKA. These are corticosteroids, thiazide diuretics, and sympathomimetic drugs, and second generation antipsychotic agents. All will have a contributory factor. The as Dr. Manjunath sir was saying, the sodium glucose cotransporter 2, this is also has been implicated, especially normal glucose level diabetic ketoacidosis. That's euglycemic diabetic ketoacidosis. Then, and more recently, the anti-cancer medications, mainly the immunomodulators that have been used, has also been implicated in development of diabetic ketoacidosis. What are the clinical features? Usually, diabetic ketoacidosis evolves rapidly within a few hours of the precipitating events, whatever may be the precipitating event. The symptoms that are polyuria, polyphagia, polydipsia, weight loss, and weakness, all these are because of hyperglycemia. The dry buccal mucosa, sunken eyeballs, poor skin turgor, tachycardia, hypotension, and in severe cases, it may result in shock. All is because of there is a depletion of intravascular volume. The characteristic Kussmaul respiration and acetone fruit breath are the common findings in case of a severe one because of the secretion of phosphotic acid from the lungs. The nausea and vomiting is sometimes accompanying factor symptoms, which will further worsen the electrolyte abnormality that we'll see later, and also abdominal pain. All these are symptoms are due to ketosis and acidosis. Abdominal pain is commonly seen, and abdominal pain correlates well with severity of it. More the acidosis, more will be the abdominal pain. So same time, we should not forget to see the other causes of acute abdominal pain, like abdominal splanchnic infarction, any gangrenous bowel or anything, because any of these also can contribute for, can be a causative agent for diabetic ketoacidosis. In the laboratory diagnosis, mainly determination of plasma glucose, blood urea, nitrogen, creatinine, ketone bodies, and electrolytes. Once the electrolytes are measured, can calculate the anion gap. The arterial blood gases and complete blood count are the laboratory investigations that are necessary in case of diabetic ketoacidosis. And in addition, electrocardiogram to see any silent myocardial infarction, blood or urine sputum cultures, which can say something about any associated infection, and even chest X-ray are indicated. Leukocytosis is one of the common findings in diabetic ketoacidosis, or even, but leukocytosis greater than 25,000 always suggests an ongoing infection, which requires further workup. The beta hydroxybutyrate levels measured by specific assay were shown to be highly sensitive and specific for diabetic ketoacidosis diagnosis. What other measures, sodium neutral method measures both acetic acid and beta hydroxybutyrate, but this is measured in some labs. This is sensitive and specific. The anion gap, calculated anion gap of more than 20 million usually supports the diagnosis of DKA. What about euglycemic diabetic ketoacidosis? It is characterized by metabolic acidosis, increased total body ketone concentration, and blood glucose levels remains less than 250. So this is also seen in 10% of the patients with diabetic ketoacidosis. Mostly associated with conditions of low glycogen reserves or increased rate of glucosuria, such as pregnancy, liver disorders, and even in alcohol consumption. So what is the treatment for diabetic ketoacidosis? The goals are, as we have seen, there is a depletion of circulatory volume, improvement of circulatory volume, which can lead to the tissue perfusion, the gradual reduction of serum glucose and osmolality. The gradual reduction is very important, as our previous speakers were actually mentioning about this. There is no, we should not aim at sudden the decrease in glucose or even osmolality. The correction of electrolyte imbalance, mainly potassium, and identification of other cofactors and treatment of the comorbid, the causes which has actually precipitated the diabetic ketoacidosis. The fluid therapy forms the main role. It is a volume depleted state. Diabetic ketoacidosis is a volume depleted state. As there is an increase in glucose in the blood, this also causes osmotic diuresis, and there is a total body water loss. That will be somewhere approximately around 6 liters in case of a severe metabolic diabetic ketoacidosis. The initial fluid of choice is isotonic saline at 15 to 20 ml per kg per hour, or 1 to 1.5 liter during the first hour. Various other IV fluids has been tried, like ringer lactate, half normal saline and all, and they have not found as advantageous as isotonic saline. In patients who are hypernatremic or eunatremic, the half normal saline infusion at 4 to 14 ml per kg per hour is appropriate, and the 0.9% normal saline at a similar rate is preferred in patients with hyponatremia. The goal is to replace half of the estimated water and sodium deficit in first 12 to 24 hours. So insulin therapy, the cornerstone, as we have seen that the lack of insulin is the main cause of diabetic ketoacidosis. Insulin therapy is the cornerstone in physiologic doses. Usually, the insulin therapy starts with a bolus of 0.1 unit per kg weight, followed by infusion of 0.1 unit per kg per hour. The recommended rate of glucose reduction is between 50 to 70 milligram per deciliter per hour. If desirable glucose reduction is not achieved, or if it is more than 100 per hour, still the additional insulin bolus can be given. When plasma glucose reaches somewhere in between 200 to 250 milligram per deciliter, insulin rate also should be decreased. Aim is not to control it, very tight control. Around 200 to 250, we have to decrease the insulin itself. The rate of insulin should be adjusted to maintain the blood glucose between 150 to 200 milligrams per deciliter until the diabetic ketoacidosis is resolved. In case if it is falling further, even dextrose can be started to maintain 150 to 200. See, potassium therapy is also very important here. Mild to moderate hyperkalemia is frequently seen. The insulin therapy, correction of acidosis and volume expansion further decrease sodium serum potassium concentrations. Initially, the serum potassium may be normal. Because of all these things, it further decreases. Potassium replacement is initiated after serum levels below 5 or 5.3 in patients with adequate urine output. So this is commonly done by adding 20 to 30 millimole potassium to each liter of infused IV fluid, that is isotonic saline, to maintain a serum potassium concentration within the normal range. In case of hypokalemia, potassium replacement should begin with fluid therapy, and insulin treatment should be postponed until potassium concentration reaches at least more than 3, or according to some people it's more than 2.5, because once the insulin is given, this pushes potassium further into the cells, and there will further depletion of potassium in the serum, where the cardia is prone for arrhythmias, and also later there can be respiratory muscle weakness also. So bicarbonate therapy is controversial, as Harsoor sir was mentioning the previous talk. So associated with hypokalemia, decreased tissue oxygen uptake, and cerebral edema, and delay in the resolution of ketosis. These are the problems with bicarbonate therapy. However, in patients with severe DKA, when bicarbonate level is less than 10 milliequivalents or PCO2 is less than 12, so deterioration of pH if not treated with bicarbonate. In these cases, it is indicated. If the pH is between 6.9 to 7, 50 millimoles of bicarbonate. In case of pH, if it is less than 6.9, 100 millimoles of sodium bicarbonate can be given. Phosphate therapy, there is no evidence to say that phosphate therapy is beneficial in these patients. So, however, in patients with hypophosphatemia, which has led to the cardiac and skeletal muscle weakness, the use of phosphate may be considered. Otherwise, it has no role. And the other state, the second state, hyperosmolar hyperglycemic state. This is also an acute metabolic complication of diabetes that can occur in both type 1 and type 2 patients. Here, there is some amount of insulin that is present in the body. In case of diabetic ketoacidosis, there is absolute lack of insulin. Here, a little some amount of insulin will be present that prevents lipolysis and ketogenesis, but not adequate to cause glucose utilization, that peripheral tissue glucose utilization. In addition, there is a smaller increase in counter-regulatory hormones like catecholamines, glucagon, and all. Compared to DKA, there is a little increase in counter hormones. The clinical features, the onset may take 4 days to weeks. It's a little longer compared to diabetic ketoacidosis. The common presentation again include polyuria, polyphagia, polydipsia, weight loss. As it is over, if it develops over a week, in weeks' time, there will be weakness and weight loss, and physical signs of intravascular volume depletion. That is a dry buccal mucosa, sunken eyeballs, poor skin turgor, tachycardia, hypotension, and in severe cases, patient can be in shock also. The neurological symptoms include the clouding of sensorium, somewhere from drowsy to mental attendation, and coma in severe cases. Occasionally, patients with HHS may present with focal neurological deficits and seizures. The effective serum osmolality is more than 320 in case where patient is severely obtunded or comatose. On the other hand, the altered mental status is rarely seen when the osmolality is less than 320. So laboratory diagnosis, again it is same: glucose, blood urea nitrogen, serum creatinine, serum ketones, electrolytes, osmolality and urine analysis, arterial blood gas, and blood count. The major cause of water deficit is glucose mediated osmotic diuresis, which leads to loss of water with excess of electrolytes. Patients typically have a more than pH of more than 7.3. Bicarbonate level will be usual more than 20, and ketone bodies are absent in plasma and urine. So the primary treatment is improvement of circulatory volume and tissue. Later that can lead to tissue improved tissue perfusion and gradual reduction of serum glucose and osmolality, and correction of the electrolyte imbalance, mainly potassium. Identification of prompt treatment of comorbid precipitating causes forms the mainstay of treatment. Again, fluid therapy. Here, estimated water deficit can be approximately 9 liters. The initial fluid of choice is again isotonic saline at the rate of 15 to 20 ml per kg body weight per hour, or 1 to 1.5 liter during the first hour. The choice of fluid for further replacement depends on hydration status, serum electrolyte levels. In case where there is a potassium, the ringer lactate or any other thing can be changed. Or in case of the electrolytes are normal saline can be continued. In patients who are hypernatremic or eunatremic, 4 to 14 ml per kg per hour of normal saline is sufficient. The goal is to replace half of the estimated water loss and sodium deficit over a period of 12 to 24 hours. The correction should be slow. In patients with hypotension, aggressive fluid therapy, just like a fluid resuscitation, is necessary. So till the blood pressure is stabilized. The administration of insulin without fluid replacement in such patients may further aggravate hypotension. So the use of hydrating fluid in the first hour of therapy before insulin causes mainly the potassium deficiency because of the dilution, as well as the insulin will drive the potassium inside the cell. So hydration alone may reduce the level of counter-regulatory hormones because by hyperglycemia, just by dilution, volume dilution. The reduction of insulin infusion rate and/or use of 5% dextrose normal saline should be started when blood glucose reaches 300 milligrams. The gradual reduction of osmolality not exceeding 3 milliosmoles per kg per hour and a fall of serum sodium at a rate less than 0.5 millimole per liter per hour is the target. Otherwise, the patient can have other complications like even cerebral edema. Insulin therapy, as there is a lack of insulin therapy, is the cornerstone in physiologic doses. Again, the dosage, the same 0.1 unit per kg body weight, followed by the continuous infusion. And the infusion rate should be low, as major pathological process in this patient is severe dehydration more than insulin deficiency. So here the replacement of the volume should be given importance than insulin. The optimal rate of glucose reduction is again 50 to 70 milligrams per hour. And when plasma glucose reaches 300, insulin rate should be decreased by 50%. That's 0.05 units per kg per hour. That's infusion. And then the resolution of diabetic ketoacidosis, and during follow-up, blood sugar will be drawn every 2 hours for determination of glucose, electrolytes, blood urea nitrogen, creatinine, osmolality, and venous pH. Here, most of the times, venous pH is indicated just to avoid one arterial prick every time we take. And there is also a correction factor of 0.03 that can be added to make arterial pH. And the other thing is, as the improvement in pH is what we are seeing, the compared to previous venous pH, the difference is actually matters. So that's even venous pH measurement is accepted. So blood glucose, when it reaches below 200, and sodium bicarbonate improves to more than 50 milliequivalents, and pH is more than 7.3, and anion gap less than or equal to less than 12 is an indication of resolution of these complications. And hyperglycemic hyperosmolar state is resolved when serum osmolality is less than 320. In this case, measurement of serum osmolality is also indicated in addition to the above parameters. And gradually, in case of altered mental activity, this one, gradual recovery from mental alertness is an indicator of resolution of hyperglycemic hyperosmolar state. And the other thing, differential diagnosis, the 2 states that are present, alcoholic ketoacidosis and diabetes insipidus, are the 2 conditions that can confuse with diabetic ketoacidosis and hyperglycemic hyperosmolar state. The complications, mainly these complications occur during the treatment. The hypoglycemia because of the over enthusiastic correction, or because of the insulin increase, this one. Hypoglycemia can be a complication. Hypokalemia, as we said, during the insulin also pushes potassium into the cells, and also because of the dilution, hypokalemia can result. And there is a possibility of cerebral edema when there is a rapid correction. That's why the correction has to be slow. So, and one more condition, hyperglycemia without obvious acidosis. So these patients encounter, they may be the patients, otherwise they would have developed diabetic ketoacidosis or hyperglycemic hyperosmolar state at a later stage. They may just be ineffective diabetes management. They are hyperglycemic. So hypoglycemia is one of the other acute diabetic complication, which we should not forget. And symptomatic hypoglycemia is always an emergency and can lead to rapid deterioration and death if not corrected promptly. Severe hypoglycemia occurs when blood glucose level is less than 50. Hypoglycemia is not a direct complication of diabetes, and almost always it's the complication of treatment. So what causes hypoglycemia? So there are many other conditions like renal failure, exogenous insulin or oral hypoglycemic agent, pituitary dysfunction, liver diseases, adrenal insufficiency, alcohol, and infection, and insulinoma is a very rare cause, and neoplasm, and drugs. And the most important will be missing a meal, and this one, insulin or oral hypoglycemic agents. Missing a meal is the main cause for hypoglycemia. So hypoglycemia most often occurs in type 1 diabetics on insulin. It can be due to an increased patient's insulin dose or skipping meals or even heavy exercise. Hypoglycemia can also occur in type 2 who take oral hypoglycemic medications, particularly the sulfonylureas. So signs and symptoms. So hypoglycemia should always be considered and immediately excluded in diabetic patient presenting with altered mental status, weakness, or stroke symptoms. Signs and symptoms. The signs and symptoms are mainly due to neuroglycopenic and autonomic manifestations. The neuroglycopenic manifestations are confusion, agitation, focal neurological deficit, seizures, and in severe cases it can be coma also. The autonomic manifestations, palpitations, tachycardia, anxiety, and sweating. The rapidity at which the hypoglycemia develops usually determines which type of symptoms, that is neurologic or autonomic. In patients with a sudden drop in glucose, the autonomic manifestations predominate. In patients with a slower decline in glucose levels, neuroglycopenic signs predominate. The management, it's in case of any altered level of sensorium or a decreased level of consciousness, securing airway, breathing, and circulation, always the important, the first step. And the hypoglycemia is glucose. The treatment of hypoglycemia is glucose. Usually IV glucose administered 25% 100 cc, usually administered and expected to raise the serum glucose by 225 to 250 milligrams. So glucagon is the second line agent that can be administered intramuscularly where IV access isn't possible. However, it is slower than IV glucose in reversing the symptoms, but glucose is always the first choice to treat hypoglycemia. Thank you very much for the patient.
Thank you, Dr. Manjunath, for that excellent description of diabetic emergencies. Very well done. Can I request Dr. Manjula Sarkar to take over and conduct the question answers and panel discussion?
Thank you, sir. First, I would like to congratulate all the speakers. They have really done a great job, and all the lectures were really excellent without saying anything. I can't see any question in the chat box. So we will just proceed for the question answers from our side, if you don't mind.
Yes, yes.
I would like to know from Dr. Harsoor that he said H1AC level should be less than 6. But what should be the acceptable level as an anesthesiologist for all our residents for elective surgeries?
Okay, what I'm tried to mention there is when there is a HbA1c level is less than 6, the chances of the glycosylation in the joint tissues is expected to be very minimal, whether
Right,
they're diabetics or non-diabetics. That is what is the meaning, what I try to convey.
right.
But then when we are taking up a patient, it is not exactly the glycosylated level, hemoglobin level that is important for us, but what is the level of difficulty that we are anticipating or expecting. Because ultimately what it is going to indicate, the hemoglobin, glycosylated hemoglobin indicates is the last 3 months level of control.
Right.
Before that, if there is already glycosylation, it is most of the time, it is not a reversible disorder. So therefore, it gives an indication, a long-term control of blood sugar levels indicated by the glycosylated hemoglobin. If it is below 6, yes, these may not have any difficulties. But anything more than that, we need to individually assess, and that cannot be the sole criteria for either taking up or not.
See, I will say for all the practical points, if it is more than 9, we say no, optimization is must and you have to control. But if it is around 7 or 8, we accept the patient and we take and we treat the patient on table, even for the elective surgeries. Do you think that is the right approach?
Taking up a case for the surgery based on a glycosylated hemoglobin, probably in my view, is slightly different from that of yours. Because what should guide us for taking up the case should be more of a blood glucose levels or the other associated the metabolic components rather than the glycosylated hemoglobin. Glycosylated hemoglobin is a slow process which is indicating only what has happened in the past. What is today probably is more useful to us. Say all the speakers were unanimous in telling that the blood sugar levels somewhere between 140 to 150 and 180.
Right.
That is a non-tight control. Say, of course, we are not discussing about the tight control regime, which is done in a cardiac procedures or the neuro procedures. We're not discussing. So therefore, merely based on the glycosylated hemoglobin for the purpose of taking up a surgery may not be a good choice, I feel. For example, if the blood sugar is controlled in the last 2 to 3 days, glycosylated hemoglobin definitely will not come down.
Yes.
So that may not be the reason for us to either deny an opportunity or take it easy also. Rather than denying the opportunity for surgery, we cannot take it easy just because the glycosylated hemoglobin is not, come down or something like that. Other panelists will answer. Yeah.
Can I add something to that?
Yeah.
See, if you take the society guidelines, I think we don't have any guidelines in India. But if you look at the Australian Diabetic Association guidelines, they recommend that if the hemoglobin A1C is greater than 9 grams, 9%, you have every right to, if especially elective surgery, you can delay the surgery till it comes to less than 9. And if you look at the UK guidelines, it is 8.5. The cutoff is 8.5. So when you look, take patients for elective major surgery, probably this can be followed. I think we should have our own guidelines because we have
depending on the patient and depending on the situation.
Yes. Elective surgery, I'm talking about if the emergency, you have to take it anyway and administer insulin intraoperatively. I just had one comment about Harsoor's presentation. I think in evaluation, we may also have to look at the diastolic dysfunction. These patients, diabetic patients, have a high incidence of diastolic dysfunction in the left ventricle. So that will also guide us to how to go with the anesthetic management.
I agree, sir. I agree with you.
Yes.
Now, I would like to ask Dr. Manjunath, would you prefer to give the bolus doses of insulin or infusion of insulin? What is your practical experience regarding this during management of intraoperative period?
Madam, higher level, the initial bolus, that's a very low, less than 10 units. Either 0.1 less than 10 units. Bolus followed by infusion will be better in case of a very high glucose level.
So you
And that
prefer
also
the
activates the receptors,
Mhm,
lower dose.
mhm. I am dealing with all my cardiac patients. So usually I prefer to give the boluses rather than giving infusions because blood sugar fluctuates quite, in very different levels. So would you advise to give me the infusion of insulin or bolus
Madam,
is okay?
infusion is only when glucose increased, boluses are better. When
Okay.
there is a severe acidosis and other impending diabetic ketoacidosis or hyperglycemic hyperosmolar state, then the infusion plays a role.
Okay, okay.
Only for increased glucose, no infusions.
Okay, okay.
Our practice is to give infusion, continuous infusion, and monitor the blood glucose
Yes.
frequently and maintain. And once you give insulin,
Yes.
it is more or less what you say, more or less imperative to look at the potassium levels, and if the potassium levels are coming down, you have to start potassium as well.
Potassium, yeah.
If you do not give infusion, what we have seen is that at the end of surgery, they become acidotic, and it becomes difficult to control. Actually, one of the speakers, I think Dr. Manjunath himself mentioned that Manjunath or Sripada mentioned about the use of insulin, low dose continuous infusion, which prevents acidosis at the end.
Yeah.
And I would like to ask Dr. Sripada, do you have any experience with continuous blood glucose monitoring and adjustment of insulin with that technique?
So I don't have personally any experience with continuous monitoring, but a lot of literature is available, and there are a good number of studies now with thousands of patients as participants, and the outcomes are very good. In the sense, it is like almost like artificial pancreas now. We have algorithms developed for the sake of injecting insulin, and there are technologies, percutaneous or indwelling electrode technology, both are available. And I think they are now practical. Maybe in a short while, we'll be practicing in India as well. Only controlling the fact right now is the cost factor, which is preventing us in implementing this. But otherwise, the literature is rife with a lot of references for using, especially for major surgeries and your cardiac surgeries.
I have received one question in the chat box by Dr. Nishant. He wants to know whether 2D echo is mandatory in patients with chronic diabetic posted for elective surgery. Dr. Sripada can answer this question.
Yes, madam. I think because two factors. One is, as Dr. Muralidhar sir mentioned, there is a diastolic dysfunction prevalent among these patients. Second is these patients are prone to have silent ischemia. We never know when the patient had an episode. And often the assessment of functional limitations is spurious. Patients do not give the actual history, and often the residents also fail to elicit the functional limitations. I think
would you advise any extra monitoring or investigation intraoperatively for these kind of the patients apart from 2D echo for intraoperative period?
So one is
for diagnosing the silent myocardial infarction.
ECG is one of the foundation stone for all monitoring. And then if there is any suspicion, we can go for enzymes as well.
Enzymes.
Yes.
Okay, so enzymes can be monitored if we are expecting the silent myocardial infarction or diastolic dysfunction.
Any unexplained hemodynamic perturbances, I think they call for immediate echocardiography and also, if possible, enzymes.
Okay.
Madam, shall I add one more point?
Yeah, please add.
Yeah, these patients do have autonomic cardiovascular neuropathy. Along with that, they have got some amount of cardiovascular cardiac what do you call this? Myopathy, cardiomyopathy will be there in these patients because of very high glucose. They usually over a period of time they develop cardiomyopathy. So you have to be very careful as far as these patients are concerned. The diastolic dysfunction, cardiovascular, autonomic cardiovascular dysfunction, silent MI, and cardiomyopathy.
Dilated cardiomyopathy.
Myopathy, that's very important, and we have to go for it is a this 2D echo is a mandatory in these patients before any surgeries.
For any elective surgery.
Yeah, yes, it's a cardio. 2D echo is a mandatory in these patients.
Okay. Now I want to ask one more question. What is the medico-legal safety if you are giving the regional anesthesia to chronic diabetic patients? Any of the panelists can answer. What is the medico-legal safety for using regional anesthesia in diabetic patient where autonomic neuropathy is already existing?
This is a very interesting question and frequently debated.
Yeah.
There cannot be any perfect answer for this question. But I can say that with whatever available medical legal references, if we can document, if we can document the extent of neuropathy patient had before surgery in a reasonably good detail, then I don't think there should be any problem in using regional techniques.
So regional techniques can be given safely if you are documenting the preoperative condition of the patient in view of autonomic neuropathy, right?
Yes, madam.
This is what you want to say.
Yeah, madam. And there is no support to say that regional technique worsen the neuropathy.
Okay. So do you think the USG guided blocks are better for these patients, or traditional or conventional blocks can be used?
There is no literature supporting any of these, but the common sense says we should go for ultrasound guided techniques. It's prudent not to injure the nerve when we can do it easily.
Okay. So training should not give the blocks in these kind of the cases, and the expert should use the blocks, give the blocks.
Can I just add?
Yeah, please add, sir.
No, in my slides, I have categorically said the peripheral neuropathy. I did not mean autonomic neuropathy. Peripheral neuropathy is not a contraindication for any regional blocks. This is categorical. And patients, because there is no doubt about the advantages of the peripheral nerve blocks whenever it is possible. But as Sripada said, it is what is required is perfectly evaluate, document it, inform the patient, and then only you proceed. And also I have added in that not only the ultrasound guided peripheral nerve blocks, the addition of a PNS, peripheral nerve stimulator, to the ultrasound will make doubly sure that we do not inadvertently injure the nerve. So therefore, I am of the opinion, yes, medical legally issue may be there, but documenting and then performing the block where it is definitely indicated and definitely beneficial to the patient is possible.
Okay. Thank you, sir. So anyone else wants?
Yeah, excuse me. Yeah. So my question is to Dr. Harsoor.
Sir.
This is with regard to this preoperative stopping of OHS, especially the gliflozin in group of drugs, which is a dangerous, it can cause euglycemic decay during the long surgeries. So you suggested and you presented in the slide saying that we will have to stop for 6 weeks prior to the elective surgery. So what is your take on that? How will you control the preoperative glycemic state if you stop it for the 6 weeks of time? And I just want to comment on that.
Yeah, the SGLT2 are a newer class of drugs which are found to be very much beneficial because they also produce a weight reduction in addition to bringing down the blood sugar levels. This is one thing. But if we go into the pharmacology of that particular drugs, they are expected to have a half-life of about only 8 to 10 hours. So going by that, even if we go 3 times, say more than 24 hours to 48 hours should be sufficient. But however, I think when the major surgical procedures, especially the cardiac and high-end neurosurgical procedures are there, there are certain guidelines, what I said, they should be stopped at least about 6 weeks before you start for the elective procedures. This is what I read about that. The rationale for prolonged stoppage and then switching over to another the insulin or other drugs, I have really not understood. But the one thing is certain, the half-life is about only 8 to 10 hours. People, I think Murli, you were in the cardiac, this thing where what, or Sarkar madam, can we just throw more light on this?
Fine. See, what we do here in our institute is the latest guideline also, we've gone through the literature which shows that minimum of 72 hours of stopping of the drug is sufficient, because as you said, that the elimination time, 3 times if you calculate, well within this time. So our guideline, we follow this guideline. We stop this medication 72 hours prior to surgery, and the metformin groups of drugs, we stop it for 24 hours prior to the surgery. And how to optimize the glycemic control during the preoperative period, that's important. You will have to switch over to either regular insulin or whatever mode of thing. So shorter acting drugs. So that is the option of doing this one. So that's what the current recommendation says. No, the minimum of 72 hours is the enough.
For metformin,
Yeah.
Yeah.
I got one more question in the chat box. Dr. Ruchi wants to know 2D echo for all diabetics, or if only ECG changes are there. Recommendation of 2D echo for all diabetic patients, or only if ECG changes are there, then we should ask for the 2D echo.
Hello. Very, very interesting question. Yes.
Yeah, I think Dr. Murali should answer this question.
See, if you ask me, I will do echo for all patients above 50 years, because diabetic or non, please, this is not evidence-based. But the thing is, in India, as Asians, we are more prone to coronary artery disease. And hence, I believe that anybody above 45 years should have a routine screening echo, what we call a screening echo, not a detailed examination, but the basic parameter like ejection fraction and diastology and any indication of valvular abnormalities, myocardial function has to be done. But if you look at the Western guidelines, there's no recommendation for doing echocardiography unless the patient is symptomatic or patients are more than 65 years. So, but we as a race have the more incidence of ischemic heart disease, and our incidences are higher. So I would like to do it starting from 45 itself. Every other day you hear a case, somebody less than 40 has had acute MI. In fact, the incidence of acute MI in our population below 45 years of age is very high. Actually, if you take the total incidence of acute MI, 25% of the people who are develop acute MI are below 45 years of age. So with this scenario, and echocardiography is available in most centers and it is non-invasive, can be done. So I'm on to the other extreme, but we have to take a calculated judgment in a given patient.
I'm fully agreeing with Dr. Murali sir, because according to me, 2D echo is going to take a role in due course of the time as an ECG monitoring system in the operation theater, and quick assessment for all the cases, all elective cases, whether they are after 4 or before 4, can be done, because that is very simple, is screening. And quick assessment can be done for all the cases. Those are coming for elective surgeries, because surgery itself is going to cause so many problems in a patient. So I'm sure that in due course of the time, 2D echo is going to be a mandatory investigation for all the surgical patients. This is what I think now.
Having said that,
Shall I comment on this?
Please comment. Please comment.
Yeah, I totally agree with the Dr. Muralidhar about this doing a 2D echo for the cardiac patients. But in non-cardiac setup, we don't normally perform the echo for all the patients. Because see, again, we'll have to individualize the preoperative evaluation in individual cases, case-based studies. So see, we'll have to assess the functional status. See if the metabolic equivalents are poor and there are other associated comorbidities which can contribute to, increased chances of coronary artery disease, like associated chronic renal failure and hypertension. When there is a previous episode of any cardiac issues, and the symptoms of cardiac disease is there, then it will be useful. But routinely for suppose some hernia hydrocele operation, operation lasting for 1 or 2 hours, if they are coming for the surgery, if there is a completely asymptomatic patient, but only thing that they have got diabetes with good glycemic control and all that is there, then I think I have only maybe one ECG is enough, and we can proceed without echo. That's my view.
Cardiac patients coming for non-cardiac surgery.
Yes,
You
yes.
mean to say cardiac
cardiac patient for non-cardiac surgery, if you look at the guideline, if you look at the approach of 7-step approach, there is no echocardiography till the end. But our situation is entirely different. That is for Western population. How much we can follow that is questionable, because our population is entirely different. Cardiac, the ischemic heart disease occurs in younger age group. So I'm going to the other extreme. I will start doing the echo from 45 years in otherwise asymptomatic patient. If a patient has known cardiac disease, symptomatic patient, you have to do it anyway. But I'm talking about asymptomatic patient, non-known to have cardiac disease. I would like to do a 2D echo for any major case coming for non-cardiac surgery beyond 45 years of age.
Dr. Murali, I'm Radhakrishnan here.
Yes, sir. Tell me.
I was hearing you for the last 15 minutes. Hello. Is it needed in asymptomatic patients, asymptomatic diabetics, mild or moderate? They're coming for non-cardiac surgery. Do you think it's absolutely necessary?
No, I'm talking about major surgery. I'm talking about high-risk major surgery from surgical point.
No, I'm not telling about high risk. Some sort of minor guarding surgery, say hernia or hydrocele or a thumb amputation.
See, for minor surgery, if the functional capacity is good, we don't have to do it anyway. I'm talking about major surgery, which there are large volume shifts and hemodynamic.
If it is your hospital practice, I don't touch on it.
No, it's not in the guideline. That's why I'm first.
That's why it's not in the guideline.
I qualified initially that my views are a little drastic because of what we see in practice is much different from what is done by the Western population.
Yeah, again, Western population. CAD is more with the Western population than Indian population.
No.
Indian population more diabetic prone. Indian population is more diabetic prone. If you're going to combine, probably they are marginal. But otherwise, CAD is more with Western population. You look at the literature.
No, we are 3 times more vulnerable to coronary artery disease. You look in literature, we are 3 times more vulnerable. And it occurs at younger age. That is the difference between Western and ours. Their average age is 65 to 70. Ours is 40 to 50, 50 to 60.
Okay, I agree.
Okay, depending.
So if it is 50 to 60, why not do it at 45? You're only doing some non-invasive investigation.
You can do anything what you want. If you want, if a particular investigation be completed on a particular patient, you can do it. Absolutely no problem. Your action justifies.
So depending on the case and depending on the surgery, it has to be decided whether to be done or not to be done. Okay, accepted.
No, I'll start doing it 45 years.
Always depend on the individual and what's the complication individual has, how he had withstood the period of time in the past. Another thing, to Harsoor, well, peripheral neuritis. Do you think if the patient is some motor deficit is shown by the patient, do you think that patient will be accepted for renal block? Your peripheral neuritis patient, there is every chance patient may have motor deficit also. And don't you look for the motor deficit also? As far as I know, it's medically legally questionable. If anybody with peripheral neuritis, if the patient has motor deficits, you are not allowed to do a peripheral block, and I mean especially neuraxial block. Am I correct?
Yeah, certainly, sir. I agree with that point. But what I was referring, peripheral neuraxial blocks, peripheral nerve blocks.
Peripheral nerve blocks.
Yes, those things, if any deficits are there, then we can record it. But neuraxial blocks, especially in a patient who is already having a motor
Deficit,
block, motor deficit, will be a questionable one, and I do not recommend that for a neuraxial blocks, either a period or the
in
spine.
short, patient with a peripheral neuritis, if the patient is not having any particular other problem, okay, patient could be accepted for a regional block, either peripheral neural block or even neuraxial. But if the patient shows slightest motor deficit, okay, go away from there and go with the GA. And again, to mind it, is this 72 hours of abstinence from the drug, is it necessary? Do we practice that?
Question is arising when you cannot give general anesthesia, and when the choice is only regional anesthesia, then you have to weigh the pros and cons and decide whether to go ahead for the regional or not. Because if general anesthesia can be given, then you can give general anesthesia. There is no problem.
Is ruled out. The thing is that peripheral, if the patient is having a simple peripheral neuritis without any motor deficit, okay, you can do peripheral neural blockade as well as neuraxial blockade. But if that particular patient is having motor deficit to minor degree, you are not justifiable, or you are not at all allowed to go with a neuraxial block. Okay, that's what I was asking.
I agree, sir. Again, motor block is not, once there is there, we do not know the exact reason why the motor block is there, and then whether we injure or not, whether we document to explain to the patient, probably it's not an issue, because I think, madam, I should tell you, there can be a contraindication for a regional or a neuraxial block, but there cannot be any contraindication for general
anesthesia.
No contraindication for general anesthesia.
Fully agreed.
That is the ultimate thing.
Can I say something?
Yes.
I to some extent agree with Dr. Harsoor. If this is a neurological symptom, and regional anesthetic is good for that patient, for that particular procedure, you document the lesion and discuss with the patient.
Discuss, yes, sir.
You have to tell the patient, see, this is the problem you already have, and we would like to give you this one, and this will not in any way affect your existing lesion. You have to explain to them, and once they agree, only then you have to do.
Yeah.
Okay. Always involve the patient in decision.
Sir, I want to say something else.
72 hours of abstinence from the drug. That's what I was wondering.
No, that is applies to the SGLT blockers, inhibitors.
Sir, can I add a word?
That is specifically applies to the sodium glucose transport inhibitors.
Sodium glucose co-transport inhibitors.
Yeah, that one. That inhibitor. So that applies specifically to that.
Yeah. Can I add a word?
Yeah, Dr. Manjunath. Yeah.
Just I want to say something about peripheral neuropathy. In case of peripheral neuropathy, the treatment for it is medical line of management. When symptoms are not improved, these peripheral neuropathy are pain complaints. In chronic pain, interventional chronic pain, peripheral nerve blocks are the treatment for it. Yeah. In case, as the sir was mentioning, sometimes there can be, whenever there is a severe symptoms like sensory symptoms also, we cannot examine motor. Sometimes motor are secondary to sensory. Even giving a peripheral nerve blocks can improve the motor, this one also, if it is secondary to sensory. Actually, there is no anything wrong with motor nerves or this one. Because patient, we are not able to examine only because of sensory component is more, it's painful. That may be the condition. And the second condition is only patient has to, patient or surgeon has to complain that because of our anesthesia, their motor, whatever the lower limb symptoms are worsened. If we take them into the account, then regional, this one shouldn't be a problem. but definitely the peripheral nerve blocks is a mode of treatment in chronic pain, especially for peripheral neuropathy. So there has been steroid injections, and recently there has been 5% dextrose injection around the nerve also has been shown to improve the peripheral neuropathy complaints.
No, the problem here is in the presence of neural deficit, and the patient does not know about it. And you have given a block, and then the patient notice that there is a deficit. This can be falsely implicated with anesthetic technique. So you have to document the deficit and also explain to the patient that you already have this, but we may be giving a regional technique, but because that is better for you. And then if the patient agrees, then you give the block.
Yes, sir. Of course, taking patient and surgeon
because
into
sometimes
consideration
patient may not know that he's having neuronal deficit.
Yeah.
So and if you give the block that time, you will be blamed for giving the block and causing the symptoms which can be manifest later on.
Sir, the situation is generally when
is important, and explain to the patient is important, and also to the surgeon also you have to tell him.
Okay.
Generally, when the patient has such a severe neuropathy as to cause a motor deficit, I feel that most of the time they have severe sensory deficit as well. Do we really need to give anesthesia for this patient? We have to think. We have often done these procedures without anesthesia, just watching over. If the patient complains of pain, we'll intervene like that. So many times it happens so, especially with long-standing diabetics with severe neuropathy, often the limb is painless.
And you don't need any anesthesia.
If you properly examine, I think you can manage without.
Such kind of patients we usually manage with the MAC. We will give some dexmedetomidine or some IV analgesics and all that. So to make the patient calm and quiet, and they will sleep off. And if there is a pain or something like that, when they are nibbling the bone or something like that, then we will give additional analgesics to add on that. Or maybe some local infiltration also, where when they go on, they can give it when there is a total sensory loss is there. Yes, I agree with you.
That dexmedetomidate is a real good choice in such kind of the situation, and it really helps. It really helps.
Yes.
Madam,
Yes.
I have a question, Dr. Kodandaram.
Yes, sir. Yes, sir. Please.
One of the very common conditions which we come across as emergencies is diabetic cellulitis, diabetic foot. Patients will be posted for emergency wound debridement and sometimes even amputation. So if the patient is having diabetic foot and comes for this procedure and is in sepsis, not in shock, is general anesthesia indicated, or can we do regional anesthesia?
This is
as you said, general anesthesia, there is no contraindication. Dr. Harsoor.
No, to whom you are asking this
Dr.
question?
Harsoor.
Can you just repeat the question?
Patient with diabetic cellulitis with sepsis in the foot comes for emergency surgery. So is spinal anesthesia can be done in this case, or should we go for general anesthesia?
Wherever it is possible.
Yeah, Harsoor, you want to take it?
Yes, sir. Please, sir. You go ahead, sir.
Yeah. If the patient is having only diabetes cellulitis, well, the patient is under control. If the patient is having severe decay also, along with probably one obstructed GA. Otherwise, you can go for a unilateral subarachnoid block. Unilateral
he is saying
block.
patient is in septicemia. Patient is in septicemia,
cellulitis.
Not
even if the patient is in septicemia, if the patient is not having decay, patient will be taken. If the patient is not having decay, patient will be taken for unilateral subarachnoid block. That's what we practice.
Yeah.
Sir, I fully agree, because once there is a severe sepsis, the chances of a patient having decay are pretty high. So in such a situation, there is definitely nothing wrong in going ahead with spinal anesthesia, because I do not see any contraindication for that, provided only the hypotension which may be exaggerated because of the consequent hypovolemia.
That's the reason, sir, I was withholding it. If
So,
decay is there, well, you treat the decay and then you can decide.
Take it up. And
At
after all these
6 hours time, if you have, you can treat the decay and bring the patient to normalcy as far as possible and then do.
If DKA is not there, then the patient.
Kodandaram, sir.
Decay is not there where you can.
Sir, Kodandaram, sir, can I add it, sir? Kodandaram, sir.
Yes.
If the DKA is treated, you can go ahead with the regional block like sciatic nerve block and femoral block. If you are well versed with this, you can go ahead with that. Sciatic and femoral block. That I can also do it. So they can avoid the complications of hypotension in these patients. Fluid overload and hypotension. That also
The
can be done.
problem, only thing what I say is that whether the patient is having sensory motor deficit, your regional block is not going to help you much. Yeah. That's one thing, especially when the patient is having a severe sepsis, I mean, diabetic ketoacidosis with sepsis, probably patient may be having sensory motor deficit. Your block may fail sometime. Your block may fail you, that's all.
Yeah, I asked this question because in presence of sepsis, it is said that it may not be wise to give any neuraxial blocks. Maybe better to go for general anesthesia only.
Sir, that is the correct answer. In a medical legal way, that's the correct way of thinking. Go with it, GA. There's no problem.
Like Dr. Harsoor told before, there is no contraindication for GA.
Yeah.
So, now, the second question I wanted to ask is, there are many situations in emergency wherein a patient is posted with acute abdomen, diabetic patients. So what is the precaution our residents who are on duty should take before accepting these cases?
See, the acute abdomen first and the foremost in a known diabetic patient, remember the DKA itself can manifest as acute abdomen. The first thing that we need to suggest is assess whether the patient has got a DKA, because there are instances where the moment you treat DKA, the pain abdomen disappears. The surgical intervention may not be required. These are the documented things. So therefore, assess first, emergency, and if it is established that there is no DKA and the pain abdomen is definitely there because it is supported by other reasons, then as I said earlier during my talk, we should not postpone or delay the surgery. We can only take some precautions with such as the managing the hypotension or for the dysrhythmias, and simultaneously go ahead with the staged correction. Say first start with the insulin fluid corrections you make, and then you continue with the acid correction and other things. So this is
so basically the keto-diabetic ketoacidosis has to be treated first and then decide what to be done.
No, I don't think, madam, because there may not be enough time for us to wait for correction of a ketosis. So therefore, first you rule out ketosis. If it is because of the ketoacidosis, then if it is there are, ultrasound or the abdominal investigation suggests that the acute abdomen is there, then you proceed. But otherwise, if the DKA is there and then the abdominal surgery is required, then definitely we should proceed without waiting further, because it can further worsen the sepsis. And
so you mean to say that treatment has to be started and simultaneously you have to proceed for the surgery?
Yeah, in one word, I can say simultaneous.
Yeah, okay,
Madam,
Madam, do you agree, Kodandaram?
No, I agree with Dr. Harsoor. What he is telling, what I understood is that patients with DKA can present themselves as acute abdomen. There may not be anything in the abdomen, no abdominal pathology, but they may present as acute abdomen. So that is one point. The second point is they may also have perforation or some other intra-abdominal problem also. They may also present and they may be having DKA. So both scenarios are possible. So we must always make sure that it is not DKA presenting by itself as acute abdomen. If there is
Probably, Kodandaram,
drop
the
of the
first
lesion
scenario,
also, then it is posted for surgery. So first control the decay.
first scenario of DKA manifesting as acute abdomen
Yes.
was invoked when we were students, or maybe about
Yeah,
20
yeah.
years. Now
Yeah.
with the advent and ease of usage of ultrasound as well as the CT and MRIs, that is, ultrasound is more than sufficient to diagnose any abdominal pathology. So therefore, the first situation will not arise. But however, from you said the teaching of the residents issue,
Yeah.
we must, one of the differential diagnosis must be a pain abdomen caused by the decay.
Exactly.
Okay,
That is
so
the
it was
point I
nice
wanted to.
discussion. It was nice discussion, and all the panelists has really given the good answers, good question. And I conclude this session, and I request Dr. Murli to give the vote of thanks, as
Thank
we
you
are
very much.
running short of time.
Thank you so much. And I would like to thank all the speakers, Dr. Megha, Dr. Manjunath, Dr. Harsoor, Dr. Sripada, Dr. Manjunath again for the excellent talks. And I would like to thank the moderators, Manjula, Sarkar, Kodandaram and Murugesan, for joining and being with us and conducting the session very efficiently. And a lot of discussion was there towards the end. And I would request Dr. Radhakrishnan, you would like to say some comments?
No, sir, please go ahead. Please go ahead.
And if we continue this discussion, I think we'll land up with hypoglycemia now. It's time for us to go for dinner.
That's it. That's it. Don't give the mic to me. Yeah, I don't
Dr.
want you.
Manjunath was saying that last complication of diabetes is hypoglycemia.
Yeah.
So we will be having hypoglycemia, not because of diabetes, but because of lack of food. Just so with that, I would like to thank you, and we will see you next week, same time, same place. Please join us, and thank you so much.
Thank you.
Thank you.
Thank you.
Bye, everybody.
Bye.
Thank you, sir.
Thank you.
Thank you.
Good day.